Hello and welcome to the Under Pressure podcast. I'm Dr. Jonathan Sackier and I'm very proud to be your host. Before introducing our guest today, it's important to specify that this podcast has been supported by MyoOne, a Canadian medical device manufacturer. Please refer to the show notes for further information about this and any disclosures. And you can be in touch with us at underpressure@nextsense.com. That's underpressure@nxtsens.com should you have any questions or suggestions, and we'll do our best to answer them. So today we've got an extraordinary guest joining us, a world-renowned figure in the field of cardiovascular surgery and a pioneer in mechanical circulatory support. Professor Mark Slaughter is an enormously experienced and innovative clinician and a very nice chap, and he's got expertise in, among other things, heart transplant, ventricular assist devices, and the application of mechanical circulatory support. Mark is professor and chair at the Department of Cardiovascular and Thoracic Surgery at the University of Louisville the Jewish Hospital, and the medical director of the Cardiovascular Innovation Institute. I visited quite a place. He's held roles in various clinical societies, such as the American Society for Artificial Internal Organs and the International Society for Heart and Lung Transplantation, and is currently a consultant to FDA's Medical Device Review Panel, a grant reviewer for the National Science Foundation, and has served 2 terms for the Health and Human Services Medicare Coverage Advisory Committee. Frankly, it's astonishing that he's got the time to talk to us. Today, we're going to explore Professor Slaughter's journey, delving into research on limb ischemia, particularly in the context of extracorporeal membrane oxygenation, which I'm going to do that again. Today, we're going to explore Professor Slaughter's journey, delving into research on limb ischemia, particularly in the context of extracorporeal membrane oxygenation, which is thankfully abbreviated to ECMO, and its relation to compartment syndrome. So without further ado, Professor Mark Slaughter, welcome to the Under Pressure podcast.
Oh, thank you so much. And thank you for the warm introduction. It always reminds me of how I've spent my time the last 20 years.
Yes, it is. I sometimes said if people have given me a nice intro for a talk, when taking the podium, I always say, I'd kind of like to have a massive MI just at this moment, because it'd be nice to die with nice words ringing in your ear. So, Mark, I have to ask you this, and I'll set a context. Throughout my training, there have been various doctors I've had the privilege of working with, training under, who had interesting last names. And I have 2 friends, Paul Fearis and Neil Fearnot, and for years I dreamed of the day I could have them both on a panel and introduce Fearis and Fearnot. Your last name, there've got to be some interesting moments as a surgeon.
Certainly, and actually for myself personally on a daily basis. Frequently patients every day are concerned and either have a joke or a comment. But similarly is most likely at the end, they always say, well, you must be pretty good if you kept that name. So that's always been somewhat reassuring. And similarly is my brother actually was a physician as well. And he started out actually in surgery. And when he was on his general surgery rotation, his 2 partners with him were Grim and Gross. So they would call overhead for the surgical interns, Grim, Gross, and Slaughter. So you can imagine that created quite a bit of laughter when in reality it was true emergencies and they were looking for a surgical intern.
Yeah, it's sort of like the joke names of law firms, but there you go. So let's get serious. Your career has been phenomenal and includes more than 600 device implants and over 100 heart transplants. Can you talk us through your journey and how cardiovascular surgical care has evolved during your career? I mean, there have been phenomenal changes, certainly in my professional lifetime and yours.
Yeah, it's certainly been very interesting for me to say I've sort of lived through a tremendous number of changes. And it really has been gratifying to sort of really see the end result. And that is a significant improvement in survival and quality of life for these patients that historically 20 or 30 years ago really had minimal to no chance of survival. So when I entered cardiac surgery, and it was sort of, back in 1990, so unfortunately 34 years ago, patients with heart failure, transplant worked, but still, quite frankly, is most of the patients were at home with a pager, had bad heart function. But nowadays, we probably wouldn't even transplant those people yet. And the other people who were sicker really had no options. So when I was at the University of Minnesota, Chip Bowman, who is the chief of cardiovascular and thoracic surgery, had sort of given me the opportunity to start working with some of the researchers there. And we started looking into sort of different forms of sort of mechanical support that might help these people. Because I'm sure you'll even remember too, and for a while we were very excited about cardiomyoplasty, where you could actually take a skeletal muscle, latissimus dorsi, off the back, drop it through the rib cage, wrap it around the heart, and electrically stimulate it.
Mhm.
And interesting, you could actually, convert it from a fatigable muscle to fatigue resistant. So there was promise, but once again, didn't quite work. And so, from an engineering point of view, sort of the idea was, well, if we can actually put somebody on the moon, you think we should be able to develop a mechanical device to sort of help these people. So along this time, as you sort of suggested, and the idea is there's partial support and full support and sort of everything in between. And besides total artificial hearts, now the LVADs, but certainly ECMO. And ECMO, has really matured. It's played a significant role and still is one of the major forms of support for patients with cardiogenic shock, or even those individuals that have known heart failure but have acute decompensation. So it's really been exciting and fun for me, to participate in sort of all forms, and including still transplantation. There's significant improvements now. We transplant people, that before we wouldn't have, with pulmonary hypertension, other comorbid diseases. And so it's really been quite the journey, and quite frankly, personally and professionally satisfying for me.
Truly. So let's focus in a little bit about ECMO. I've did a bit of reading and learned that it was first used to support a patient who suffered severe lung dysfunction after a motor vehicle accident in 1971, and then 5 years later in a baby with meconium aspiration. Could we start by expanding on ECMO, because maybe people don't really know a lot about it who don't use it, and how widely it's typically used in patient management in cardiovascular and trauma care?
Yeah. So, as you say, historically, it really was sort of a form of partial or sort of miniaturized cardiopulmonary bypass. So, in these individuals that had specifically to start with what were really sort of acute respiratory conditions, where ventilator management alone was not sufficient. And similarly, in those patients, even if you did support them with ventilators for prolonged periods of time, due to the inflammation and the injury itself, they basically ended up either a pulmonary cripple or they died of their respiratory disease. And it also became apparent along the way that for patients with acute cardiovascular collapse, that you could then support the individual, resuscitate, liver, kidney, lungs, and even make sure that the brain is getting adequate perfusion. And so the idea was it should work, and there certainly were many potential indications. But I believe also this year it was the 37th anniversary. So I think, as you sort of suggested, it's not really a new idea or a new technology. But many years ago, the cannulas that we had, the oxygenator, the pump to sort of push the blood around were quite rudimentary compared to what we have today. So although they were used in life-saving situations, initially the outcomes, we'll say, were sort of so-so. So it really was only done in specialized centers, those people who were believers and or that were really wanted to help mature the technology and make it better. So the idea is, it really is sort of a form of partial cardiopulmonary bypass that could be inserted either centrally or peripherally through many different mechanisms. So it was ideal for the use for emergency settings and even in trauma, because many of those patients, as you know, they may have an inhalation injury from smoke. or perhaps just due to the blunt injury in pulmonary hematomas, broken ribs, inability to take deep breaths. So it really became, the perfect technology to temporarily support these patients while they recovered from these injuries, such that they could then, walk out of the hospital and still lead a normal life.
Right, right. Yeah, it's quite phenomenal, and it was used a fair bit during COVID, I believe, wasn't it, to
Oh,
support
yeah.
a lot of patients?
So one of the big increases was actually during the initial H1N1
Oh, right, yes.
influenza outbreak, particularly at least in the United States. And around that time period, which I believe was around 2011, that sort of time period,
Mhm.
the technology had really matured in that the cannulas were much better. They were smaller, thinner, had very good hemodynamic profiles, lower resistance. You can get tubing packs that are heparin coated. The centrifugal pumps cause very little hemolysis. And so it really became the ideal situation for these patients with acute lung injury. They had a very high mortality. And then, even if they did survive, many of them had chronic pulmonary problems. And it became apparent that actually you could save lives compared to those patients that just stayed on a ventilator. And since that time, the use has really skyrocketed.
Yeah, yeah. So, expanding on this, a recent article, Proactive or Reactive, Best Approach to Limb Ischemia in Peripheral Veno-Arterial Extracorporeal Life Support, you discussed different strategies for managing limb ischemia. Can you elaborate on the key findings from that research, including what are the challenges of such support and the potential benefits of a proactive approach compared to a reactive approach in the context of ECMO? And how is the balance of such strategies evolving to benefit the patients you care for?
Yeah, and I think the word evolving is still very important here because although in the also registry there are now over 100,000 patients, we have registries international worldwide. It still is a very heterogeneous population, and similarly is although there's some fundamentals that we all agree to, there still are differences in approach and practices. So we don't have all the answers yet for sure. But as you suggested, the idea is, and it's become very clear through recent times, first H1N1, that it clearly saved lives. And then in COVID, we started to understand, though, that if you're too late, you're just too late. And on the other hand, it does have, some potential for adverse events and particularly when used for peripheral insertion, which you sort of alluded to, and I think we'll talk a bit more about here in a second, and that is limb ischemia. So you always have to balance sort of too early versus too late. And certainly, though, the idea is if you want to save lives, too late's a problem. And I think there are certain, indicators now. The idea is the amount of time on a ventilator. It seems like if you've been on a ventilator more than 10 or 14 days and you're still on significant amount of inspired oxygen and positive expiratory pressure or PEEP, that those individuals then at that point, you'll have a very limited chance of recovery. Still, it's not no, but it's limited. So we have indications for, when is we're sort of narrowing down to what would be the sweet spot. On the other hand, you don't want to do it too soon because there are some patients that with appropriate mechanical ventilator support, prone positioning, and other evolving therapies still might stabilize or improve. But one of the biggest problems that we see, because the preferred approach in most centers is what we refer to as peripheral insertion. And so that is, it's easy access, it's quick, it can be done by, quite frankly, many specialties, depending on which center you're in. But the idea would be is to access the femoral artery and vein percutaneously, past the guide wires, and insert the cannulas to establish ECMO. And the problem is in these individuals, though, depending upon body size, whether or not they have peripheral vascular disease, the size of the femoral artery, femoral vein. As you can then imagine, there are concerns with limb ischemia. And certainly those individuals that develop limb ischemia with peripheral insertion, it is a fairly morbid event. So we have to find ways to appropriately select cannulas, have a good approach to insertion, and then how are you going to identify and manage and limit what might be the complication of acute limb ischemia, that is a result of the therapy itself.
Mm. So we've mentioned limb ischemia as a critical condition, severe complications, including compartment syndrome. Can you touch on how important early detection can be in preventing such complications?
Yeah, well, it's extremely critical because I had sort of suggested is those individuals that develop clinically relevant lower extremity ischemia significantly impacts morbidity as well as mortality.
Yeah,
So the idea is the lungs may actually recover or the heart may recover, but due to the complication of this severe lower extremity ischemia, it could actually still result in death, including possible loss of parts of the limb. But I think, as you sort of suggested, the idea one is sort of prevention, because there is a lot of evidence now that using a distal perfusion catheter, so the arterial cannula, right, is passed retrograde to establish the flow, to get flow to the kidneys, the upper body, the bowels, and depending upon how much the heart is ejecting, you'll get flow back up to the left subclavian, maybe in the left carotid. So the idea is, though, if you can put a small cannula antegrade down the limb, there is some suggestion that generally speaking, it does help. But having done that, it still doesn't eliminate the risk of lower extremity ischemia. And even when using these sort of preventative techniques, the risk of lower extremity ischemia is probably somewhere between 5% and up to 20%. And when they do, the concern is they might require fasciotomy. They might ultimately lose, toes, part of the foot, and worst case scenario is amputation. And so identifying it becomes critical. And there is no currently established way. You can try things like a pulse oximeter, on the flow, you certainly check for pulses. But I think sort of a new innovative way is this idea of compartment pressures. Because in an ischemic limb, as you can imagine, is that you would think that there would be changes. And that's what we saw in orthopedic surgery, in injury, whether it's trauma, setting bones, things like that. And that's where I think that we have a real opportunity with the new technology from Myo One for
yeah,
early detection that would then result in treatment to prevent these complications and further improve the outcome, for
yeah,
what really has matured into a wonderful technology and
yeah.
saves lives.
So I'd like to expand on that in a minute, Mark. But your point about symptoms, when I first came across this concept or revisited, because I'd seen these patients, recently saw a gentleman who became septic, went
Yeah,
into a low flow state, missed compartment syndrome in his arm, and he lost his arm, his below the elbow. And a very dear friend of mine, who is a magnificent scientist, fell ill with COVID. And exactly as you describe, the heart and lungs recovered, but unfortunately, the low flow state caused him to lose a lot of bowel and developed compartment syndrome in a leg. And thankfully, they were able to save the leg, but I think he had about 15 or 16 operations.
yeah,
And the issue is, isn't it, that the symptoms and the signs are not particularly objective, like pain. Actually,
right.
with the broken bone, I swore that if the doctor asked me one more time, was the pain getting worse, getting better? I wanted to hit him because, you know, hey, it's such an airy fairy sort of a thing. So,
Yeah,
I mean, given your deep involvement in the pathology associated with advanced heart failure, such as using ECMO, How do you see the management of compartment syndrome fitting into the broader landscape of critical care? And we've hinted at that. And what about the need for multi-specialty approaches to the management of ACS, and how you develop that collaboration within your facility? So a bit of a three-parter for you.
Yeah. As I say, first of all, you're right. When it hurts, it hurts. I
Yes,
don't understand this partial smiling, a little smiling,
yes,
no smile,
exactly.
right? The answer is it hurts.
It hurts. You got
Right?
it. Absolutely.
Make it better, right?
Yes,
I don't
stop
care
the
how
pain.
much of a smiley face I have to check.
Yeah.
But you're right. So I think there's a lot to discuss there. So you have to remind me sort of towards the end to make sure we
Okay.
covered it all. But I think you use a very good example though. The idea is other sort of types of injuries hurt. So at least the patient can complain though, right? And I say we can argue over how bad is bad, or how much of a smiley face. But a patient can actually say and point to it hurts. And so the problem in these patients are the majority of them are sedated, most likely on a ventilator. And I say, as we use ECMO now, as you sort of suggested, though, for sepsis, for other types of sort of trauma patients. So it's not just heart failure, it's not just isolated lung failure, but centrally, they're essentially all sedated, majority are all on a ventilator. And so they don't have that opportunity to point to something and say, this hurts. And similarly, is when you start talking about sort of injury from low flow, low blood pressure, ischemia, the idea is it's subtle. It's not the same as breaking a bone. A lot of it is related initially to sort of nerve injury because the nerve in that area, right, is very, very sensitive to hypoxia. So if you're awake and alert, you would notice that they have sort of numbness or tingling or maybe even changes, right, in motor function, because that nerve becomes hypoxic and injured as well. And once again, though, is these patients, can't wiggle their foot, they can't wiggle their toe, they may or may not be able to sort of point to their arm. And a quick sort of side note, sort of even glad you mentioned it, because for us recently, we've actually had two patients in the ICU intubated, after sort of a complex heart surgery, and they had infiltration of the IV in their arm. And once again, very difficult to assess. And once again, by checking compartment pressure, we were able to identify what was upper extremity forearm ischemia that then required early fasciotomy. The arm completely recovered. So the idea is, in the past, what you didn't recognize till very late and irreversible, we now have an opportunity for earlier detection. But it's very difficult to sort of, as you say, through routine exam, questioning the patient to identify what might be an ischemic limb. Now, there certainly are some things that may be indicators, such as color, right? So one leg may be a little bit more less pink,
Yeah.
more pallor, things like that. But it's subtle, and it doesn't necessarily mean it requires intervention. It may sort of point you in the right direction. Many of these patients are on other medicines, inotropes or vasopressor agents that similarly make it difficult to some type of skin mechanism, to look for flow or saturation. So that in itself doesn't work. And so this idea, though, I think of checking compartment pressure, that's almost, I'll say, sort of irrefutable.
Yeah.
Because if you think of it in many ways, is if I have some blood flow in, and whether or not outflow is, because even if I have venous obstruction, but with normal inflow, that limb is at risk.
Yeah.
So it really is a combination of the two, even. And so it helps you assess those patients that may have partial venous obstruction, partial arterial inflow, where you'd say, oh, well, the arterial flow is not bad. But the reality is the combination of the two is going to result in compartment pressure changes that are an indicator, though, of ultimate ischemia.
Right.
So I think it's a unique way to sort of preemptively identify these patients that you can then intervene and prevent these devastating complications.
Maybe you could expand a little bit, and I'll come back to the other parts of the question. Well, I'll remind you now, actually. The one was the value of a multidisciplinary
Oh,
approach. And one of my thoughts about that, or questions about that, is if it hurts, the patient's conscious and it hurts, what about putting in a block, right? But, traditionally people have been reticent to put in a block because then their patient won't experience pain, which is a symptom. That's so the multidisciplinary approach of blocks, what you did in your institution, and then I want to talk about the value of continuous pressure monitoring.
yeah. So you're correct. And so we have evolved into a multidisciplinary team, and it's has tremendous value. And so in our cardiovascular ICU, which is where all of our ECMO patients go. So one is we have a dedicated ICU. So we have doctors 24/7, all of which are educated to look for these sort of problems, to sort of treat them. We have people from different backgrounds, which is extremely helpful. We have critical care doctors that were anesthesia critical care trained, cardiac anesthesiologists, actually emergency room doctors, right? And they're quite aware of sort of the acute changes in extremities, as well as the surgeons. And we have very well trained nurse practitioners, as you say, and then anesthesiologists. So the patients are seen by a multidisciplinary group with people that have slightly different backgrounds that actually bring an approach that maybe you wouldn't have thought of because of your training or background, and it's extremely helpful.
Yeah.
So, so we've evolved into a multidisciplinary approach. Patients are seen 24/7, and they go to a specialty unit, which has significantly improved care and outcome for these patients.
Yeah. So, to expand then to the value of continuous pressure monitoring, how you perceive that rather than taking a spot measurement.
Yeah, and I think that's true for any therapy, right?
Yeah.
Whether it's sort of low cardiac output, even respiratory status, and or as you say, sort of changes in the lower extremity, because it's the trend that's probably more important than a single isolated value or
Right.
even a single isolated physical exam,
Yeah.
right? It's the serial exam then that recognizes the changes, and it's the sort of change in the trend of that sort of injured body part. And in this case specifically, the lower extremity when you use peripheral ECMO. So the idea is that to start with, as you say, you put these cannulas in, you establish flow, everybody's happy. But once again, is to start with, it probably was relatively ischemic because these patients are on multiple medications, their blood pressure is low, their oxygen level is low, their PO2 may be less than 50. And so they don't get good oxygen, they don't have good blood flow. So to start with, no matter what you use to measure, it probably is worrisome. So then the issue becomes is what do you do for sort of serial measurements that will then give you an indication? And I think what you're sort of suggesting here and what we're starting to become big believers in is this idea of continuous pressure monitoring. Because even in a lower extremity, as say when you first put it in, the pressure may be abnormal, for various reasons. But the idea is if an hour later it's getting better, then the answer is great, right? We're not going to intervene yet. We're just going to keep an eye on it. And it may be better an hour or two later. But on the other hand, 3 hours later, it may start to decline. Or from you even originally put it in, right? It may look bad and it doesn't get better at all. So, this idea of continuous monitoring where you can look for a trend I think is critically important, in any sort of monitoring device that is going to result in intervention or change your therapy. So continuous monitoring, just as a concept, is much better than intermittent spot monitoring or spot numbers because they don't tell you the whole story.
Yeah. Yeah. It's like trying to standing outside a cinema, and there's the individual photographs and trying to work out what a 3-hour movie is all about. Um,
Exactly.
So there's people have looked at other ways of evaluating acute compartment syndrome. One is to use near-infrared spectroscopy, NIRS technology. I always thought it sounds like an awful thing, NIRS. It's just
That's right.
it's a terrible acronym. Um, how does it compare to the methodology that you've mentioned, continuous pressure monitoring for these patients? And what about challenges in its use?
Yeah. So I think NEARS itself is a great concept,
Yeah,
and in certain scenarios works. But it sort of assumes, though, that you have the ability to really sort of measure flow, oxygenation, and content. And it sort of goes through sort of the skin, right, for lack of a better term, and we'll say for our audience and listeners. So the problem becomes, though, is the skin not infrequently will be relatively ischemic. But a relatively ischemic skin does not necessarily correlate, right, to deeper ischemia and deeper problems. And so it might give you an idea of superficial ischemia, but similarly is if you don't have a pulse, and many of these patients, with ECMO, it's continuous flow. So they may actually have relatively good flow, but no pulse. And that's why actually a pulse oximeter also doesn't work well. It's helpful, but it isn't consistently helpful because you frequently have a diminished pulse. The skin may be relatively ischemic, and similarly, you still may have relatively low oxygen level. So all these things in combination, it's not a consistently good method to use in ECMO. And I think that sort of is borne out in the sort of idea that in most of these major centers, it's not consistently used by everyone, nor has been demonstrated to consistently improve outcomes. There's some, random reports and anecdotal experience, but universally, it doesn't seem to work, in all patients, in all centers, all the time. So
yeah.
that's why I think we're still searching for an additional way, to look for a way to find ischemia, identify what is clinically relevant that requires intervention.
Yeah, so instead of looking for a surrogate for pressure, measure pressure.
Yes.
In other words,
Yeah.
I've actually looked at NIRS for intraoperative evaluation of
Yeah.
bowel ischemia, and played with it many years ago, and it didn't bear out. But maybe it's just not been refined. So another sort of clinical scenario problematic is patients with a high INR, international normalized ratio, must introduce some layers of complexity when dealing with these difficult cases. What are some key considerations navigating these, and how do you ensure optimal outcomes while mitigating the risk of anticoagulation?
Right. So certainly, most of these patients, have multiple comorbidities, other problems.
Yeah,
And for ECMO, as a rule of thumb, you generally speaking would prefer to anticoagulate them. With the newer technology, though, the cannulas, the tubing, the oxygenator, and even the continuous flow pump, it turns out they really require less anticoagulation than historically we knew about. And so it is still sort of a fine balance. But I think, as you're sort of suggesting and implying, is that in these lower extremity limbs where you may have diminished blood flow and sometimes diminished venous return, specifically if you put the cannulas in the same leg. So if you put the venous and arterial cannula in the same leg, quite frankly, it sort of increases the chances of having a problem. But
right.
also, then the issue is it's more important to make sure they're reasonably anticoagulated, because if you have low blood flow, stagnant flow, then not only do you have ischemia, but you're going to start thrombosing, at the microvascular level and the small vessels.
Yeah.
So it's critically important to make sure that you're appropriately anticoagulating these people, because you can actually sort of add an additional injury to what is sort of a low flow state if not appropriately anticoagulated. And on the other hand, you have to be very careful that they're not over anticoagulated because you might cause bleeding in these damaged lungs or other organ systems for which you're sort of treating them with this ECMO system.
Yeah, so primum non nocere comes to mind,
Yes,
right?
yes.
So, as a cardiovascular surgeon, you encounter compartment syndrome in various forms beyond ECMO related cases. Can you explore some of these scenarios, such as limb compartment syndrome post revascularization, the vascular surgeons? And how do you typically approach diagnosis and management of some of these less, I wouldn't say less obvious cases, but less obvious cases of compartment syndrome?
Yeah, so and nowadays there's actually been sort of I'll say more opportunities, to see this because certainly intra-aortic balloon pumps, similarly that we frequently use in cardiovascular surgery and peripherally inserted can cause problems. We have newer partial support systems, the Impella pumps. I refer to them as a pump on a stick, and then even in patients. Where you put femoral arterial lines in, brachial arterial lines, because many of these patients have had other procedures in the past. Their radial arteries may have been used, or you may even want to use the radial artery for coronary artery bypass grafting. Now it's a commonly used conduit, but there's multiple sort of opportunities now that many years ago even wouldn't have happened just because we have other technologies and we have different approaches to the operations now. So for the most part, though, these things are still sort of identified by clinical changes, and it's still not the most accurate. And generally, it can be very late in diagnosis. So I think the idea of this sort of pressure monitoring for any of these scenarios could be a tremendous breakthrough and advantage for patients. And as I had sort of mentioned a few minutes ago, even for upper extremities, whether it's IV infiltration, they have a brachial artery where the forearm doesn't look good, intra-aortic balloon pumps, because then it allows you to have earlier intervention. And there's just so many other sort of ways to develop compartment syndromes and ischemic events in limbs that years ago we may or may not have been either aware of, or it wasn't sort of a potential complication from the therapy or treatment that we were providing.
Yeah, I'm recently talking to a colorectal colleague who's seeing it in patients who are undergoing very lengthy robotic laparoscopic procedures with the legs in lithotomy. So, yeah, it's interesting how these situations develop. So, we've mentioned peripheral artery disease, limb ischemia, and acute compartment syndrome, which align with vascular and musculoskeletal issues. How do you simplify patient management in these scenarios compared to things like hearts and lungs
Yeah.
induced problems? Yeah.
Well, I think even, to go back a second here and expand, because you're right, there's other specialties now that are sort of seeing these complications. And although I think they now have started to recognize it, but as you're sort of suggesting, these lengthy abdominal operations, particularly when done endoscopically, that requires insufflation because the inferior vena cava, the iliac veins, may be compressed for prolonged periods of time. And as I suggested earlier, it's not always, arterial blood flow limited. It's that
Venous
ratio.
congestion.
Yeah. And so if you have severe venous congestion or return of flow, you may have the same arterial inflow and even some relative hypotension, but that differential becomes so important. Uh, and then is what happens, right, is even once you relieve it, though, it doesn't mean it's not going to go away because then you have an ischemia reperfusion injury.
Yeah.
And so those cells swell, as does the compartment. So you always have to be aware of sort of the ischemia reperfusion or sort of the secondary effect of, oh, I fixed what was the problem, but it still may result in a significant injury. So, you may have sort of solved the issue of either outflow or inflow that resulted in, temporary ischemia. but it doesn't mean that the problem went away because you have ischemia reperfusion. And in those scenarios, those cells that now sort of have that relief, though, will swell, the compartment may swell, and you still can have secondary compartment syndrome and significant ischemic injury, even though you corrected what was that imbalance of flow. So
Yeah.
you always have to, in the back of your mind, the best way to sort of, I'll say, not only prevent but detect these issues is you have to have a high degree of suspicion. So you always have to be on the outlook. And not only the idea is, okay, I fixed the inflow or outflow problem, but the answer is, I have to be aware that there still may be secondary injury, and I have to find a way to at least intermittently, if not continuously, monitor that area that I believe may have had ischemia or an ischemia reperfusion injury.
It's fascinating the way that we have to think about these things. Mark, you've taken us on an incredible tour de force about the topic. Is there anything that I've failed to ask you that you were hoping I would? And if so, please leap in. And if not, can you provide our audience with a sense of excitement, what the future holds for your specialty, and maybe a pithy take-home message?
That's right.
I
I don't
love the
know about
word
any,
pithy.
yeah, pithy take-home messages because fundamentally I'm an engineer by training and a cardiac surgeon, so we're not terribly pithy. But I think the idea is that the technology has evolved, and as you had asked, the idea is proactive is better than reactive. So I think that is critically important because still, it's generally speaking, it's much better to be 10 minutes too soon than 10 minutes too late. And
Yep.
very rarely are you going to be too early that sort of results in a bad outcome because you were too early. But 10 minutes too late is much, much worse than 10 minutes too early.
Yeah.
And similarly, is the technology does work, and you need to get these patients to a center or a program that has access to all this technology. And as you suggested, has a multidisciplinary team because clearly it's the best approach. And then I think there's all these different methods for trying to sort of monitor for this injury. And the issue sort of becomes there isn't one that we know works best. But on the other hand, I think this idea of continuous monitoring, and clearly, as we've discussed, the end result of the ischemia, whether it's inflow arterial flow or outflow venous obstruction, results in compartment pressure changes. So if there's ways to measure it and learn from our orthopedic colleagues, I think there's a real chance for detection, prevention, and earlier intervention. And I think this idea of the Mile 1 pressure sensor probe, we now have had experience with about a dozen patients. And in about a third of them, we have altered our therapy and have prevented significant injury. So I think it's something that certainly should be considered and for other programs to evaluate as to how it might work in their program where they sort of see these very sick patients because otherwise the morbidity and mortality from this complication of limb ischemia compartment syndrome is significant. And I think there is new technology and the concept of continuous monitoring, continuous pressure evaluation is at least a novel way. And I think with time we'll realize is probably a better way to look for these injuries.
Yeah. So, Mark, it's interesting. You said you'd changed your therapy, and in a number, you'd acted sooner than you would otherwise have. There's been some work that's done that shows, and it didn't really surprise me that a lot of the cost in these situations is actually in the patients who have an unnecessary fasciotomy. And it's
Yeah,
sort of like whenever we do something in medicine that isn't necessary and you get a complication. So, like fasciotomies, they stay in hospital longer, they need skin grafts. The patients you're looking after, they're profoundly sick. The last thing you want to be doing, surely, is doing any unnecessary interventions. Have you seen that the continuous pressure monitoring protocol prevents you doing a fasciotomy where otherwise you might not, you might have done.
100% yes. And because frequently, as you say, with the multidisciplinary approach, we then would consult our vascular colleagues because
Right,
they have more experience with the fasciotomy themselves. And
right,
so they frequently come by and, appropriately it's like, oh, it's pale, it seems tense. And their reaction is, I have a hammer, that's a nail. And so the idea is sort of, why not? And on the other hand, we can now actually not only measure it as we've talked about in that one time slot, but we can then say, oh, look, it's close, but not quite. And we can then intervene, do things to actually reduce the pressure that then results in not having to do what would turn out in hindsight, to be an unnecessary fasciotomy.
yeah,
Because it seems like a relatively minor procedure, but on the other hand, it's actually quite morbid. And it's even more morbid in this patient population.
yeah.
So it certainly gives you the opportunity to avoid what might have seemed like the right thing to do, but in hindsight turns out may not have been necessary. So it's just another way that it adds an adjunct to improving the outcomes and these very sick patients.
Yeah, absolutely. Well, I think it just remains for me to say to Professor Mark Slaughter, thank you so much for joining us today, for sharing your work, all you're doing, and all you will do for patients. Mark, thank you very much. Really appreciate it.
Oh, and thank you for having me. And I think these things are so important because, as you know, doctors these days get a lot of their information through social media,
Yeah.
podcasts, webinars. They don't necessarily read books anymore. And quite frankly, and you know as well as I do, because you've also written a lot, is by the time the book is actually published, the information may be a year to 2 years old. And so I
Exactly.
think things like this are critically important. And hopefully, maybe in 6 months or so, we get together again, and
I'm
discuss sort of what we've done, how it's affected our practice. Because I do think this is a way to communicate in real time with other doctors that have concerns or interests that really keep them updated. So
yeah.
kudos to you for doing this
Oh,
because I
it's my
think it's a
pleasure.
great way to educate individuals.
It's very kind of you to say, Mark. It would be delightful and be even better if we could do it in person over an early
Yeah,
morning cup of coffee. I would like that very much. You're a prince.
yeah.
So all that remains now is to thank you, our audience, for taking the time out of your busy day to listen and, really think about it. It's like having the opportunity to hear someone like Professor Slaughter, who's got enormous experience, and to help our patients. That's what we are here to do, right? So please share this with your colleagues who might not have come across the Under Pressure podcast yet. Post on social media about it because, as Mark said, that's the way we all communicate nowadays. I've even got a TikTok account. And if you've got suggestions of other areas you'd like us to cover in the Under Pressure podcast, please write to us at underpressure at nextsense.com. That's nxtsens.com, underpressure at nextsense.com. Thanks also to Maya One for supporting this podcast. And now, me, your host, Dr. Jonathan Sackier, please, everyone, stay safe, stay well, stay curious, and relieve the pressure. Bye for now.